Good afternoon, everybody. Welcome to today's National Virtual Summit presented by SAMHSA Gaines Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's summit is titled Advancements in Crisis Response, Preparing to Pivot, which includes two panels. The first panel is on leveraging the opportunity for 988 in your community with the presenters, Dr. John Draper, Lucrece Pierre-Carr, and Jennifer Battle. I will introduce them shortly. My name is Mike Hatch, and I'm a Senior Project Associate at the SAMHSA Gaines Center and Policy Research Associates. Before we start our presentations, I have some housekeeping items to review. The views, opinions, and content expressed in this presentation and discussed do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or in regards to the technology, please type them into the Q&A pod found on the bottom of your screen. At the conclusion of this presentation, we will address as many of your questions as time permits. We will also be conducting a couple of polls throughout the event and appreciate your participation. When you see a poll pop up on your screen, such as this one, please enter your responses. And we'll go over those results in about 5 minutes or so. Today's sessions are being recorded and the slides will be disseminated via the Gaines listserv following the event. We will also notify you when the recording is posted to the SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of each panel. Please note this certificate is for personal portfolio use and we are not able to provide CEU credits. There is also American Sign Language interpretation for this event. The interpreters for today are Justin Anderson and John Gratzer. There is also live captioning for today's event. To view live captioning, click Live Transcript CC and then select Show Subtitles. We'll take a quick look at today's agenda. Coming up next, Roxanne Castaneda will provide opening remarks on behalf of SAMHSA. She will be followed by presentations from our speakers. I'd like to turn this over to Roxanne Castaneda, who is a public health advisor at SAMHSA and the CMHS task lead for SAMHSA's Gaines Center contract. Roxanne?
Thank you, Mike. Hello and welcome to everyone. SAMHSA would like to take a moment to thank the Gaines team, Michael Hatch, Connie Milligan, Dana Brew, Sam Rogers, Ashley Sabatino, and Erica Ihara for their excellent work in preparing this webinar. In a recent presentation, SAMHSA's acting director of the 988 effort, Dr. John Palmieri, reviewed the system in need of transformation. He stated that too many Americans experience suicide and mental health crises without the support and care they need. In 2019, 61.2 million Americans had a mental illness and or substance use disorder. In 2019, there was approximately 1 death by suicide every 11 minutes in the United States. From 1999 through 2018, the suicide rate increased by 35%. 100,000 overdose deaths in 12-month period through April 2021. And for people aged 10 to 34 years, suicide is a leading cause of death. Since 2005, the National Suicide Prevention Lifeline has helped millions of individuals in emotional distress. 46,000 calls received in 2005, 3.6 million calls, chats, and texts received in 2020. From these examples, it is clear for the need to strengthen crisis responsiveness. SAMHSA is committed to answering the question of someone to talk to, someone to respond, somewhere to go. Today, we welcome experts in the field who will further discuss the advancements in crisis response. Mike?
Thank you, Roxanne. And now I'd like to briefly introduce our speakers. Dr. John Draper has over 30 years of experience in crisis intervention and suicide prevention work and is considered an international expert in crisis contact center practices. Since 2004, he has been the executive director of the SAMHSA-funded National Suicide Prevention Lifeline, now also the 988 service, overseeing all aspects of this service, including its subnetworks, the Disaster Distress Hotline, and the Lifeline's partnership with the VA in administering the Veterans Crisis Line. Lucrece Pierre Carr is the director of the Crisis Services Unit within the Intellectual and Developmental Disabilities Behavioral Health section of the Texas Health and Human Services Commission. She oversees the policy program implementation and procurement statewide, state-funded activities of the mental health crisis, forensics, and jail diversion programs. Ms. Pierre Carr has overseen the successful expansion and implementation of these programs across Texas since she started employment with the state in November of 2012. Prior to working for the state, Ms. Pierre Carr had over 12 years of experience providing direct mental health services in outpatient mental health and permanent supportive housing settings, serving various populations, such as persons with serious mental illness involved in the criminal justice system, persons who are elderly, and persons with a history of homelessness. And last but not least, Jennifer Battle is the Director of Access at the Harris Center for Mental Health and IDD in Houston, Texas. She oversees the Harris Center Access Hub, which includes the Access Line, the Crisis Line for 39 Texas counties, the regional provider of the National Suicide Prevention Lifeline, soon to be 988, the Southeast Texas Regional Suicide Care Support Center, and the Harris Center Community Outreach Department. In collaboration with the Houston Police Department, Houston Fire Department, and Houston Emergency Communications Center, Ms. Battle leads the 911 Crisis Call Diversion Program for the first program of its kind in the United States. She also leads the implementation team for the agency's Zero Suicide Initiative and serves as an advisory council member on the Mayor's Challenge to Prevent Veteran Suicide. Ms. Battle serves on the board of the National Associations of Crisis Organization Directors and is the co-chair of the National Suicide Prevention Lifeline Steering Committee. She serves on the Clinical Advisory Council for the Crisis Text Line and is a Crisis Text Line volunteer. She's also the Crisis Center Site Examiner for the American Association of Suicidology. The results from our first poll for this session, it looks like everybody's pretty close to evenly spread across where areas you represent, with looks like our urban areas leading the way, and fairly spread evenly once our law enforcement, judicial, and corrections. Looks like the bulk of our folks are crisis services, government, and community-based providers on this call. Thank you for participating in that poll. And now I will turn it over to Dr. John Draper to begin the presentation. Dr. Draper?
Thank you so much, Mike. It's great to be here with you all. We'll go to the next slide. Just a note. SAMHSA does pay for my work. They don't pay for my words. So if I say something you don't like, please blame me. Go to the next slide. You know, we are at a momentous time, and I'm really excited to be here today to talk with you all about it. But in order to give it some perspective, we're going to go back in time to 1963, when President Kennedy signed into law the Community Mental Health Centers Act. And that law was striking, hopefully, a nail in the deinstitutionalization coffin. That was the idea, or at least create deinstitutionalization for the first time in the United States and commit to it and enable stigma against mental illness to be put behind us. But boy, do we have a long way to go from 1963. In fact, when the Community Mental Health Centers Act came out, the idea was then to take as many people out of the hospitals as possible, to get them into the community, to get the kind of care, recovery, and healing in the places where they lived, worked, and loved. So they would not be in these abominable institutions where they were being warehoused for centuries. The idea was to change that course, and it was only the beginning of a very long road. In 1964, they actually changed the law again along these lines to deinstitutionalize people, keep them from getting into hospitals unnecessarily by changing the involuntary civil commitment law. At that time, before that, it was all you had to show was somebody was gravely disabled to put them in a hospital against their will. Now they not only had to be seriously mentally ill, but also a danger to self or others. So you had to show that they were both mentally ill and dangerous. Well, the idea was a good idea, I think, to try to keep people out of hospitals and raise that bar and make it harder. But the problem was that it was going to be a long time before the community was really able to take care of the number of people who were being deinstitutionalized. And as a result of that, people were languishing in the communities, in their homes, and on the streets, not being able to get care. So in 1968, interestingly, 911 was announced by AT&T, and that was the beginning of a public safety response, essentially, to persons with mental illness, because a lot of families and individuals who were not able to get care in the community could only get it in the hospital. And the only way you could do that is to show they were dangerous. And the only way you could show they were dangerous was to involve authorities to say that they were dangerous. So we began this cycle of people going from their homes, being picked up by police, taken to emergency departments against their will, perhaps going to hospitals against their will, or hopefully an outpatient clinic if they were lucky, and a worst case scenario, into jail. Next slide, please. When we were talking about a 3-digit number just a few years ago, I was talking with my daughter who is, she's graduating from college now, so she knows everything. And so I don't do anything without asking her. And so I asked her a few years ago what she thought about this 3-digit number for mental health and suicidal crisis. And she's had her own mental health challenges in her life. And she said, "Dad, I think this 3-digit number is going to do more than anything could possibly be done to reduce stigma, perhaps even eliminate it throughout the United States for people with mental illness." And I said, why do you think that? And she said, well, right now we have a 3-digit number for medical emergencies. If we had a 3-digit number for psychological emergencies, people would know that they're real and that they require a really different response from people who are caring as opposed to people who are scaring, like police officers. Go to the next slide, please. It is going to be very different than 911. 988 is different in a number of ways. Of course, it's building on an existing service. It's a new number for an existing service, but what makes it different in a few ways starts with its centralized routing character, meaning that all the calls, in this case to 988 or even the 10-digit number, will go to us at Vibrant, and we, through our telephony platform provided by Intrado, will send the contacts to the nearest crisis center in the network, and if they're busy, we'll roll over to backup centers. So this enables us, in the event if a center is unable to answer a call, to make sure that every call is answered by rolling it over to a backup center. We can't really do that with 911. There's also the ability to provide centralized quality assurance, which is also something that is not currently done for 911. The other thing that's really, I think, important to remember is that you can phone 988 and get a service that in and of itself can reduce emotional distress and suicidality. It is a free 24/7 behavioral health crisis service that has an immediate impact. We'll talk more about that in just a little bit. But in the event you need dispatch services, it can provide dispatch services in many cases, typically alternatives to 911 and typically mobile crisis teams where needed. Next slide, please. So this crisis care continuum that I'm sure many of you have heard about, that is the alternative to sending out police or ambulances or firefighters to persons who have a mental illness. What 988 could do ideally, and one day hopefully will in communities across the country, is provide this kind of crisis care continuum. This is a model that is currently active in parts of Arizona. This is Tucson in particular, where about 80% of the time, and we see up to 90% of the time, when people contact the crisis line itself, they can resolve the issue over the phone. In the event a dispatch needs to occur, often they can send out mobile crisis teams. And in the event they send out a mobile crisis team, about 70% of the time they can resolve it in the field. And then if they need to be transported to another facility other than an emergency department, they can take them to a crisis stabilization unit there, and who can immediately accept them. And 65% of the time they're discharged to the community. And if they have wraparound services in the community to support them once they're discharged, most of the time they can stay in the community. And that is the ideal situation. And I would imagine what President Kennedy imagined for a crisis community behavioral health care system to be in effect in 1963. Our next slide, please. Currently, this is the way it looks. I mentioned our routing system. If you contact our number, it tries to route you to the nearest contact center. That's by area code. So it doesn't always get you there, not until there's some kind of geolocation might that be enabled. But in the meantime, we route by area code. And if that center's busy, it rolls over to a backup center. You're also going to get an automated greeting when you contact the Lifeline. And that introduces you to the options of pressing 1 if you're a veteran or member of military service, or 2 if you're Spanish speaking and want to speak with a Spanish speaking counselor. We have national backup centers. We also have crisis chat and text services as well. Please go to the next slide. So how is it going to be different? How is this existing service going to change with a 3-digit number? Certainly the scale of access, its visibility, this 3-digit number that looks a little like 911, but is very different. Hopefully will penetrate public awareness, maybe make it easier for people to both remember and dial the number. The scope of service, we expect that over time, it won't be just seen as a suicide prevention service, but also as a mental health crisis service. And also emphasize that crisis care continuum over time as we're able to build that out. There's also an important notion of equity of access, that we want to make sure that this service is equally accessible to all persons in suicidal mental health crisis. That includes people with functional, linguistic, and access needs. You also want to make sure that people have a choice, that if they want to contact us by phone or chat or text, that they have that option to get care in the way that they need it, and also provide follow-up services to make sure they're okay after that contact ends. We also want to make sure we're providing access to specialized services to serve historically marginalized populations at high risk of suicide, like LGBTQ+ youth, American Indian, Alaskan Native, communities of color, rural individuals, and other high-risk populations, older adults, youth, and neurodiverse individuals. There's a lot more stakeholders in this in investing in this service. There's more states funding this service. The federal government is funding this service. And so there's a lot of people saying, we want to make sure that this service is doing what it's supposed to do. So we will see a lot more stakeholder investment and scrutiny of this service. Go to the next slide, please. Mobile crisis teams. Now, I think this is a little bit of an inaccurate photo, because they're typically mobile crisis teams unmarked, and that's the beauty of them, is they look like just any other vehicle, typically a van. And I worked on a mobile crisis team for 7 years before I got into the hotline business. And to me, it was a revelatory experience of keeping people out of hospitals effectively. About 90% of the time, we were able to keep them out of hospitals here in Brooklyn. And typically what happens is it's a person who's unable or unwilling to get care, but is seriously mentally ill. So there needs to be some care that comes to them. And so that's what we did for 7 years. And it was enthralling, exciting, and I have many wonderful stories to tell you about that, but no time now. Next slide, please. So to give you a sense of where we are with these wonderful services, they don't exist everywhere, but about 83% of our crisis centers say that they are able they do exist in the areas that they cover. That doesn't mean that they exist in proper number, that there's enough mobile crisis teams to go around and to respond, but 83% of them say that they do operate, and many of them can dispatch them from the crisis center. In fact, about half of them say that they actually are the ones who operate the mobile crisis teams. So the coordination between them and the mobile crisis dispatch is pretty seamless. Go to the next slide, please. We're going to be building on the mobile crisis services that are out there and going to help to create a community of practice of mobile crisis services. We're working with a couple of researchers to survey mobile crisis teams across the country. It's the largest survey that's ever been done of mobile crisis services. We hope to eventually not only build a national database of mobile crisis teams to make it easier for us to dispatch them and follow up with them, and to get information is needed to make sure that people are actually seen. But we also want to make sure that we're providing a community of practice and helping them share practices in ways that will help them all help them all be better at what they do, and hopefully research them and evaluate them and show the public that they're doing what they're supposed to do. Go to the next slide, please. So where's Lifeline in 911? And let's talk a little bit about that. We're really good at approaching all contacts with a collaborative attitude. We know the best way to keep people safe from suicide is for them to prevent their own suicide. And the best way to do that is to help calm them, engage them, help them feel cared about and less alone. And then help activate their own strengths and supports in their lives. And we're very effective at doing that. And so about 2% of the time, we are going to need 911 dispatch. Most of the time, we don't need it. And more than half of that time, more than half of that 2%, are people who are willing to collaborate with us and say, yes, please do call 911. There's fewer incidences of contacting 911 with crisis chat services, online crisis chat services. That's primarily because most of those users are younger, typically under 25, even under 20. And they have less access to lethal means often, and they also have more access to people like parents who can keep them safe. We do expect over time that 988 will deflect unnecessary mental health calls that really 911 does not need to manage, but are much more efficiently and effectively managed by 988 and crisis center services. And you'll hear a little bit about that later. We estimate about 5 million, a little less than 5 million of calls one day could be potentially deflected from 911 to 988. Next slide, please. We do have a number of relationships across our centers with 911 services, what are called public safety answering points, PSAPs, but they're mostly informal, and we would like to formalize them, have MOUs where we could more properly exchange protocols and information, so we could have a tighter continuum of care and chain of care to make sure that people are actually seen and cared for and get the information to hospitals that are actually seeing them that will help them better assess them. Next slide, please. One of the ways in which we encourage those collaborations between 911 and our local centers is the NINA Suicide Prevention Standard. This is actually the one from 2013. It just was updated really last month. So this is a slide featuring the older version, but you can find the new version. It's called the Suicide Prevention Interoperability Standard. And you can just look it up, NINA Interoperability Standard online, and you'll be able to find it. But it details all the ways in which crisis centers, local crisis centers, and local PSAPs can work together effectively to help keep people safe in their community. Next slide. We're also looking to expand our 911 and 988 collaborations nationally by working with the National Emergency Number Association and the National Association of State 911 Administrators, also wanting to establish a community of practice between 911 and crisis centers across the country. Next slide. I would love to give you our next speaker. That's Lucrece Pierre Carr, who's I understand also a Texan. I'm a native Texan too, Lucrece, and after you, Jennifer Battle's another Texan. So we've got a number of people whose hearts are in Texas here.
Thank you so much. And I'm actually from Illinois, so I'm not sure if I'm going to claim being a Texan, but yes, I've been living here for 20 plus years, so I might as well. Thank you all so much. Good afternoon, everyone. My name is Lucrece Pierre Carr, and I'm the director of the Crisis Services Unit here in HHSC in Texas. Thank you so much for having me. I am delighted to be here to talk about what our big old state of Texas has been doing in preparation for 988 and share some information about our crisis continuum of services. Next slide. All right, so this slide is our timeline of activities in preparation for 988. In 2019, Vibrant awarded HHSC the Lifeline Capacity Building Grant, which covered fiscal years 2020 and 2021. That grant was approximately $3 million. The goal of that grant was to increase Texas's in-state answer rate. So essentially for more calls to be answered here in Texas. Prior to this award, Lifeline centers in Texas have been answering calls with no funding from the state. In 2020, Lifeline centers started expanding primary coverage across the state. Texas is huge, as you might have heard, 254 counties. HHSC worked with the Lifeline centers to divide the counties needing coverage. Prior to this funding, the Lifeline centers were answering local calls. But there were 200 plus counties needing coverage. And so we divided that amongst the 4 Lifeline centers that are local mental health authorities, which I'll talk about later what a local mental health authority is. Also in 2020, in demonstrating HHSC's commitment to sustaining the Lifeline, HHSC dedicated a portion of federal mental health block grant funds for Lifeline centers to continue to answer calls beyond the capacity building grant period. That funding extends through 2024 at this point. Additionally, HHSC dedicated 5% in mental health block grant funding, crisis set aside dollars for the Lifeline, which also extends through 2024. In 2021, Vibrant awarded HHSC the 988 Planning Grant, which called for states to create a roadmap for implementing 988. That grant was approximately $180,000. Through that grant, the Texas 988 Coalition formed. We held meetings from April 2021 through January 2022 in planning for 988. We have representation from a variety of stakeholders across the state. Also in 2021, Lifeline Capacity Building Grant ended. HHSC made much progress with answering calls in Texas, though we didn't meet our goal of 70% answer rate just yet. However, from 2018 to 2021, Texas has seen an increase of 92% of calls answered in state. In 2018, we're answering about 31,000 calls. In 2021, we're answering upwards of 59,000. Also in 2021, at the end of the 87th legislative session, which for us ended in June 2021, the Texas legislature passed Rider 58, which authorized HHSC to complete a study of the adequacy and efficacy of the existing Lifeline infrastructure in Texas to determine state preparedness to comply with the Federal National Suicide Hotline Designation Act of 2020. Currently, we've been holding meetings, monthly meetings with most of the same stakeholders that participated in the 988 Coalition. The result of these meetings will be a report which we're drafting right now to submit to the Texas legislature by September 1st of 2022. In 2022, HHSC submitted the final 988 implementation plan to Vibrant. Also, HHSC applied for the SAMHSA Cooperative Agreement Grant and was awarded about $8.3 million in funding, again, for the Lifeline centers to expand workforce. In 2022, HHSC did reach 100% of our primary coverage goal. We met that in April. I see the slide says March. We were a little late, but we did meet the 100% coverage goal. And in 2023, our legislative session begins in January of 2023. The goal is to reach the in-state answer rate of 90% by 2024 with the funds received from the SAMHSA Cooperative Grant. Next slide. So this slide is on Lifeline Network in Texas. And before I get into that, I want to share a little bit about our crisis continuum in Texas. Dr. Draper talked about crisis continuum, and I want to share what's happening in Texas. So in Texas, there are 37 local mental health authorities and 2 local behavioral health authorities that operate an array of crisis programs here in Texas. HHSC contracts with these entities to provide a variety of behavioral health services, and each local authority has a catchment area. Some may have one, like Harris Center, which is huge, and they have enough with Harris County. And some may have 21, for example, Texas Panhandle, which is a very rural, covers a very rural area in Texas with 21 plus counties. Our Texas legislature began funding crisis services back in the 80th legislative session, which was around the 2008-2009 biennium. And appropriated approximately $80 million towards crisis services alone, which was a huge amount of funds. Through that initiative, we were able to establish 24/7 crisis hotlines and mobile crisis outreach teams that reach all 254 counties here in Texas. HHSC also funded other crisis programs through a competitive process based on community need and available funding. To date, HHSC allocates approximately $170 million in funding to the local authorities just solely for crisis services. Just a brief description on some of these services: crisis hotlines. Again, 24/7 telephone service operated by trained crisis staff, providing crisis screening and assessment, crisis intervention services, mental health and substance use referrals, and general mental health and substance use information to the community. The crisis hotline here in Texas is an integrated component of the overall crisis service delivery system and is accessible toll-free throughout each local authority service area, covering all 254 counties. Additionally, we oversee mobile crisis outreach teams, or MCOTs for short, as we call them in Texas. MCOTs provide emergent care, urgent care, crisis follow-up, and relapse prevention to children, adolescents, or adults 24/7. And again, MCOT services are available in all 254 counties. Some local authorities subcontract with local county sheriff's departments to deploy a certified mental health deputy to address individuals in crisis. So these are mental health deputy programs. We also have inpatient psychiatric bed programs where local authorities will subcontract with private psychiatric hospitals to provide inpatient psychiatric services for individuals who need that level of care. Additionally, across the state, most of our local authorities operate a variety of crisis facilities. Some may operate one, for example, a crisis respite, and others have a whole continuum, maybe 3 or 4 crisis facilities. These facilities are staffed with mental health professionals, medical professionals, peer providers, and they offer assessment support services to achieve psychiatric stabilization to individuals who need the services. Some of these facilities that I'm speaking about are crisis respite programs, crisis residential programs, extended observation unit programs, and crisis stabilization unit programs. Again, the facilities vary by the individual symptom acuity and intensity of services at that facility. So Lifeline Network in Texas. So you see here the 5 Lifeline affiliated call centers in Texas. The Suicide and Crisis Center of North Texas, the Harris Center, Integral Care, Emergence Health Network, iCare, call center of Tarrant County. 4 of the 5 Lifeline centers in Texas are local mental health authorities. So the Suicide and Crisis Care Center of North Texas is not, and they cover about 29 counties in Texas. In addition to operating their 24/7 crisis hotlines, the 4 local authorities also answer lifeline calls for Texas, and some of them even answer crisis hotline calls for other local authorities. Next slide. Okay, and this slide is just on resources and linkages in Texas. Lifeline centers have written procedures for providing access to resources, making referrals for services, and activating emergency services for callers outside of the Lifeline Center's local service area. Next slide, please. Callers requiring emergent or urgent care are warm transferred to the crisis hotline of the authority in their county of residence or current location. Next slide. And so here are just some priorities for Texas with regard to 988 implementation. First one is a big one, and HHSC met a milestone of providing 100% primary coverage in Texas in April of 2022. And so that goal associated there is really to increase the number of calls answered in Texas, so individuals will have access to those local services. And also you can see the other priorities here, excuse me. With number 4 in evaluating Texas Lifeline system for adherence to vibrant best practices, we've also been reviewing our standards and our rules and our laws to see where we might be more in alignment to vibrant best practices, and ensuring that we're not more restrictive in our standards as well. Next slide. Keys to 988 success. And so we've identified these different buckets, if you will, of what the foundational elements for Texas in ensuring that we have a successful implementation of 988. So text and chat we have 1 local authority, Integral Care, who they cover Travis County, which is a large county in Texas, and they have started that work for us with answering text and chat. But we are working on building that infrastructure. Again, increasing our in-state answer rate, that is our goal, and that's what we've been actively working on since we were receiving the capacity building grant in 2019. Statewide coverage. And so again, Texas is huge. We receive a huge volume of calls. So we've met our primary coverage goals. And so now we have that backup coverage that we need to address and we're working on. Funding and sustainability. We have invested a lot of our mental health block grant dollars towards this initiative. And so we'll continue to work on diversifying that funding, but we're so thankful that we are able to use those dollars. And then follow up and crisis continuum, unified follow-up protocols, and so forth. Next slide. Okay. And this slide is just on some barriers that, some states I'm sure are familiar with, barriers and challenges that we've been actively working on all of these, but the local workforce is has been a huge challenge for our Lifeline centers, and we've been working with them on some options and alternatives. We've been working with Vibrant. Text chat adoption, again, we're working on that. 24/7 coverage. Our focus now is on getting that backup coverage managed, funding and sustainability and expansion of 988. Next slide. All right. And so with that, this concludes my portion of the presentation. I will now pass it on to Jennifer Battle with the Harris Center, who is one of our local authorities. I know Jennifer is a champion for the Lifeline and oversees the excellent work they're doing in Harris County. So thank you, Jennifer.
Fantastic. You know, I have to say, I totally had not thought about John being here from Texas and then having HHSC in us. So, you know, I think that that's fair. You know, I saw some people in the chat from Alaska, you know, who gets credit for being, you know, the largest landmass. But, you know, down in the lower 48, we got a lot going on here, as I know everyone does, though, across the country. So, woo, 988, y'all. Everybody just take a deep breath. Whew, so that we can reset and get ready to go. Next slide, please. So thanks, Lucrece, for sort of setting up the vision of, you know, what happens here in Texas specific to how our Lifeline network is arranged. I know that, you know, there's 50 states, so there's 50 different ways that people are trying to figure out how to meet this amazing and exciting charge of making 988 available to everyone who needs that immediate emotional support across the country. So our state, of course, does it our way, but we're hopeful that, you know, this is helpful to other folks from other parts of the country as well. So she mentioned our local mental health authority is called the Harris Center for Mental Health and IDD, which of course stands for Intellectual and Developmental Disabilities. We are the largest local mental health authority in the state of Texas. Super shout outs though. I saw some of our local mental health authority partners in the chat earlier. So I'm so glad everyone's here, and together across our 37 local mental health authorities, we are charged with providing behavioral health and IDD services to people across our great state, regardless of their ability to pay. So this slide just gives you a little bit of idea about the scope of folks that we serve here in Harris County, which of course also is the largest county in the state of Texas and the third or fourth largest county in the U.S., depending on, you know, the given day. We have in our county usually upwards of 4.5 to 5 million folks that we serve in our given area. Next slide, please. So this is my house. So this is a wonderful picture of our behavioral health access hub. And again, I know that there's various versions of this hubs happening everywhere across the U.S. So I always think it's fun to see what it looks like. So this is what it looks like. I will say it looks a little bit lonelier now in post-COVID times because we've given people the opportunity to work both in-house and remotely, depending on what their comfort level is, depending on where our COVID numbers are in our community. Our center, of course, is available 24/7, 365. Overall, across all the different lines that roll in through our Access Hub, we're talking to about 32,000 people or so a month. We have 53 full-time degree crisis line counselors, 16 full-time access line specialists who don't have to have a degree. And then we also serve as the hub for our state COVID emotional support line. So we have 8 full-time COVID emotional support line responders. And of course, for the purposes of this webinar, we are one of those 5 hubs for the National Suicide Prevention Lifeline. And we cover 42 Texas counties out of those 254 that Lucrece mentioned. And we are the contracted crisis line provider for 39 of our Texas counties and 6 of our local mental health authority partners. So there's a lot of things that are happening within our crisis center. And I think this is one of the most important parts to me of this conversation that we're having with folks all across the US. You know, if you are, I know we have a lot of our crisis center folks here on the call, so shout out to all the crisis centers. But if you're not with a crisis center and you don't know somebody at your local crisis center, this is the time to reach out and get connected. There is a lot of subject matter expertise in your local crisis centers. So please make sure that you're making those connections, which is why those 988 grants that, those 988 preparation grants that Lucrece and John mentioned were so important because it was really an opportunity to get stakeholders together and talk with each other so that you can learn about who's doing what in your community. And what you'll find, again, are those 200 crisis lines and crisis centers across the US who are already providing amazing crisis line services in your local communities and in your state. So find them if you don't know them, they're good people. And if you're having trouble and you can't find the folks in your community who are doing the crisis line work, you can always reach out to John over at Vibrant, or you're welcome to reach out to me and we can help you get connected as well. And I'll share my email address in the chat in just a little while. Next slide, please. So this is what Texas looks like. I just kind of, again, wanted to give you an idea of scope and scale. This kind of southeast corner there in the orange, that's my region. So this is when I mentioned those 42 counties that we're covering, that's us there. And then you can kind of see how it's broken down. So I know that many states are looking at doing something like this. So we just kind of wanted to show you about what that's looked like for us so that you can see what are the possibilities for how your different crisis centers in your state can share the load. In my little corner here of orange, we are covering about 38% of the state volume for Lifeline currently, and our expectation for what that will look like when 988 starts to really go. Next slide, please. The other thing that you heard John and Lucrease talk about was, what's been happening over time. The other reason why it's really important to, as we sort of pivot toward 988, to talk about and connect with your local crisis centers is that we've been doing this for many of us for many years. The Harris Center has been connected with Lifeline since basically from the very beginning when Lifeline first started. And so, over the years, depending on capacity and our ability to sort of, find funds on our own, we may have taken, just a few hundred calls, a month, until now when we have that wonderful investment that you heard Lucrease talk about. You can see the increase that happened between 2018, 19, 20, and moving forward. So it seems very obvious, but we have to say, when you invest in the work of your local crisis centers, you're going to see an increase in the number of the people that we can serve. Those capacity building grants made a huge difference in our ability to answer those calls in state. So it's the difference between, some of you may be like, what does that mean, answer calls in state versus answer calls out of state? So what that means is that if we don't answer a call within a certain amount of time in our call center, that call immediately then reroutes to one of the national backup centers, which you heard John mention. And we're so grateful to have those national backup centers. But what I'll also say is that we want these calls answered as close to home as possible. And the reason why it's good for us to be able to answer these calls as close to home is because we have all the resources, all those wonderful things that you heard John and Lucrease talk about, that crisis continuum of care, those mobile crisis teams, the outreach services. We know, how to get people connected and what people might need locally. If someone ends up at a national backup center, they're going to get warm, empathetic, non-judgmental care the way any Lifeline caller should get. But those national folks may not know about the wonderful mobile crisis teams or the great crisis walk-in centers in your community, or you may live in a more rural area and you may have to have really done some work to figure out how you're going to get care out to folks in that community, and who to call. They don't have all of that. And so often what can happen when we get these calls that are answered out of our states is that we might end up calling too many times out to law enforcement, or too many times encouraging people to go to emergency rooms just because they didn't know what else to do. So we want those in-state answer rates high so that we can get as close to local as possible to have those local referrals and responses to get people the right level of care. So we're really excited about that. And that's what that means when you hear us talk about that. And that's the other benefit of working with your local crisis centers, is because most of your local crisis centers will know how to do those things and how to get those resources in play that they need. Next slide, please. So what have we been doing? Y'all, I feel like I have a 988 meeting every day. So if you're in your office and you feel like you're having a 988 meeting every day, just, give me a boop boop in the air and know that I'm thinking about you. It is literally the most exciting project I've ever worked on. And I'm so grateful that this is happening during my professional career. But, there are some days where I just kind of want to lay my head down on my desk and maybe have a tear or two, because it can feel like there's a lot of pressure on us in the community to make sure that we're doing this right, and that we are in connection with all of the other components and pieces that are going to make this the amazing outcomes that you heard. John's daughter expects from us, right? People are expecting this to really be a game changer when it comes to lowering that stigma and doing everything we can to connect people to the care that they need. So what have we been doing? Again, it feels like every day, but maybe not quite. We're having monthly meetings with our statewide 988 stakeholder. Look, I have typos, sorry about that. Our 988 stakeholder work group. This has really, really been an important piece. And again, comes from those grant dollars that we have from Vibrant to help us get those state stakeholder groups in place. So, and there were people in those groups that I hadn't met before, people from different parts of our state agencies, people from our EMS and 911 centers who were very excited about this project. And so those monthly statewide stakeholder groups have been very, very powerful. Then we have monthly meetings as well with our HHSC 988 implementation team. So this is Lucrece's team, the folks who are working and designated inside of our Health and Human Services Commission at the state level to work with us to make sure that the funding is in place, the resources are in place, the planning is in place to successfully launch this in our state. And then we have monthly individual center meetings with our designated HHSC 988 liaison. So this is a person who's been assigned to our centers, each of us, the 5 centers, to make sure that we have what we need, that, what are we accountable for? What are the things that we said that we were going to be working on since our last meeting? And the same from us, like what the things that we asked for HHSC for them to talk to us about, what they've been working on and what we've been asking for as far as moving toward next steps. And then we also have monthly meetings with the 4 local mental health authority call centers who are going to be answering 988. And this has been really powerful. And the reason we've been doing it with these 4 particular centers is, again, as you heard Lucrece mention, we all kind of work for the same state agency and the same umbrella. So we have, for our local mental health authority crisis lines, we already work under a specific umbrella of expectation. We already all use the same language, we use the same definitions. So we all have the ability to deploy mobile crisis teams. So us working together to really do inter-rater reliability. Are we all sort of on the same page around how we are connecting with callers both on our local mental health authority crisis lines, and then how that extends and expands across what will be happening with 988 and our lifeline calls. And one interesting thing that we did as part of our 988 planning grant was we were able to use some of those funds to be able to send some of our supervisory teams from our center to do in-person site visits at 2 of the other local mental health authority call centers. We didn't get to do the 3rd one because y'all, El Paso, our friends over at Emergent, that's a 13-hour drive from Houston, just to be clear. That's how big Texas is. So, and this was during, high COVID time, so we weren't at a place where we were ready to fly anywhere. But we were able to drive up to Austin to see our colleagues at Integral Care. I know some of them are on the call today. Thanks for hosting us. And also to see some of our colleagues in Tarrant County, which is Fort Worth. So I see some of y'all too. And there's really power in that ability to connect with people who are doing this work. Doing crisis center work, doing crisis line work can often feel kind of lonely and isolating because there's often really only one of you in each municipality. Most cities and even regions don't have more than one crisis center, nor should you. But if you don't know that there's this giant national network of crisis center leaders and people who are doing this work, it can feel very lonely and isolating. So if you are a crisis center person on this call today and you feel like you are not connected in a way that feels good or empowering with other people doing crisis center work, again, please reach out to Dawn or please reach out to me. so that we can make sure you get connected. There's the National Association of Crisis Organization Directors, there's the International Council of Helplines. There's a lot of groups out there that are here to support you in this difficult and challenging yet wildly amazing ride that we're on to provide these services to our communities. Next slide, please. All right, so you heard Lucrece mention like some of the challenges that we are facing. I would say of all the challenges that we're facing right now at this moment, it is 100% workforce. So again, if you're in your office and this resonates with you, please, like clap a little bit or, whatever you need to do. Like, you're not alone. Like, this is the one thing that makes me like be able to sit with this in a reasonable way is that pretty much every person I've talked to at call centers across the country is kind of sitting in a similar space. So here's how we're doing it. We have kind of 3 pieces of workforce that we're really focusing on to try to figure out how to be even more creative than we always have been. So we have recruitment related issues. So you saw earlier in my slide where I told you I have 53 full-time crisis line counselors. And it may seem like that's a lot, but when you look again at our slide where we showed you how many calls we have and then that we're expecting that to potentially double or triple, we're looking at probably needing about 70 in order to really meet the expectations of what we feel 988 is going to be bringing. So we need more folks, and we're having a really difficult time with recruitment. So I have added the crisis line counselor, which is what we call it at my agency, as a hot job. And we have other hot jobs at our agency too, which are typically around more like direct care, like nursing, psychiatric technicians. So we successfully lobbied our HR department to add crisis line as a hot job, which means that we're a large agency. Remember, we have probably like 2,600 employees. So on any given time, there's a couple of hundred jobs on our agency website. So being a hot job means that our jobs kind of go to the top of the list. So if you're an average person that's just coming to our website and is going to scroll through jobs instead of like scrolling farther down, you'll see those hot jobs right at the top. So that's good. Also, we've successfully lobbied our HR department to allow us to give a referral bonus to internal staff for successfully recruiting somebody for the position. This was important to me because I feel like the most successful referrals are from the current staff. And I know over the years that we've had some wonderful referrals for folks to the positions. And there are referral bonuses for other types of positions at the agency. And so I really wanted this to be something that was specific to crisis line counselors as well. And it is now, so we're very excited. This is pretty new information, so I can't give you any metrics yet of how effective it has been, but maybe reach out to me later. I'll give you some updates if I can get some metrics on it. The other thing that we're doing, which is a little bit scary for me, but also pretty exciting, is that we're beginning recruitment for crisis line counselors from our 42 county region. Remember my pretty orange part of the state I showed you? So we felt like since we were going to be serving folks from that region, that it made a lot of sense for us to be able to local invest, right? People who know those communities well. And so we now, thanks to our good friend COVID, we have the ability to work 100% remote. And so this way we can recruit folks and have folks that work in any part of our 42 county region. And so it's great for us for a lot of different reasons. Again, this is really new, so I don't have any metrics to share with you yet, but we're really excited about kind of thinking differently from a recruitment standpoint. Retention. Y'all, I feel like I live in a 2 steps forward, 1 step back world, right? So in a lot of days, like we've done so much work trying to get recruitment in place, and we get a full training class. And then by the time I get people into training, I have had one of my current staff decide to leave, and we're dealing with turnover. And, not all turnover is bad, right? Like we have a lot of folks in our agency who we have big agencies. So again, people finish their master's degrees, they move on, they go do other things. But they still need to, well, we still need to fill those positions. So we're excited for them to go have other opportunities, but we're like over here crying because we're like, no, we need to have those seats filled. And then of course we have people that are just burnt out, y'all. It's a tough job. It's a difficult job. So part of our retention has been, about a year and a half ago, right around when COVID, like right after kind of the first COVID, we added weekly debriefing group with an external clinician. So we have sort of everybody on the team assigned to go at least once a month. And then we have a certain number of positions in those weekly debriefing groups so that people can attend more often if they feel like that's helpful to them. That has been wildly popular with the staff. It has been so important. And then from a leadership perspective, at the end of every month, I get a de-identified, like one-page high-level overview of what the staff is concerned about and what they're happy about. And then I use that with the program leaders to specifically see if there are things that we need to really be paying attention to. Are there policy-related issues or whatever it is that we can do? This has also been especially important with the shift from everybody being in person to the majority of the team being remote, and how we can best sort of navigate and balance providing the excellent level of supervision and staff support that we need to provide in difficult jobs like this. The next thing that we did in partnership with our agency's benefits office was to do market research to look at adjustment of our crisis line counselor salaries and make sure that we are using internal calibration, right? So this has been difficult because it's the position in the crisis line are also kind of a challenge from recruitment, because if we pay the same and I'm trying to hire somebody that's going to work, Tuesday through Saturday from, 3P to, 11P, and I pay the same as somebody who can just go and walk into one of our awesome, amazing, like in-person clinics and work Monday through Friday, 8 to 5, then oftentimes people aren't going to choose me because they're like, why would I come work these like evening, weekend, middle of the night shifts if it's just going to pay the same as I can go work a regular Monday through Friday shift and pay the same. So really working to try to make sure that we were competitive within our own organization, and then making sure that we were competitive within like positions in our community. But the challenge is, as I said before, there's not really a lot of other like positions in the community. So really trying to figure out what that looks like. The good news is that the market research firm did come back with a recommendation to adjust our salaries up for our positions. Again, that's just been a recent development, so I don't have the metrics on it yet. But I'm feeling good about it, and I'm feeling like it was something that needed to be done. So we're pretty excited about it. The other thing that we've been doing for retention is we did an equipment audit for our staff who are working remotely. It feels like forever ago, but it was really only 2 years ago when, in the space of a week, we basically sent our entire team home. Y'all remember back to April 2020, if you weren't already remote, we were like, hey, you got a laptop at home? Like you got a pair of like Beats that you can plug in, like, go. And so, over the last, year and a half, we've really been working to make sure that, everybody on team has an appropriate agency laptop, that everybody has, agency provided headsets, that if they want in our call center here, everybody has double monitors, etc. So this way we are making sure if people want that, they have it. Does everybody have a hotspot? So just in case they're having internet problems at home, that they don't have worries about connectivity. So this has been really important for the team. Again, just to make sure that they feel resourced effectively and that they have everything that they need to effectively do their job. Next slide, please. Christy, I do see your question in the chat. Who do we use? We use a local clinician who has a lot of experience working with folks who have suicidal ideation. So it was somebody that we knew we could trust to hear the difficult parts of what we do. Even though there's a lot of great clinicians out there, we do believe that a lot of clinicians aren't really ready to hear about the type of calls that we take on a daily basis on the crisis line. And that's been a really wonderful relationship for us. So the last piece of workforce that we've really been focusing on is trying to leverage internal agency partnerships. Because again, remember, my recruitment's going slow. So we can't just wait to be able to recruit people. Those calls are still coming in. So we need to be creative around how we can use the tools that are already within our organization and maybe shift some things around. So we've been working in partnership with our peer services department at our organization to look at them helping us develop like I'm going to say warm line-esque. We're not going to be like a full warm line, but we do have calls. We've been running some data looking at how many calls that are coming in to Lifeline that aren't crisis calls, but are more of that emotional support call. And so trying to develop what a flow would look like for people to be connected with our peer services department for non-crisis needs, but people who still need that warm, empathetic listening support. The other thing that we're doing is we have already worked to develop a completely virtual training because, like I said, we're trying to recruit people from other parts of our state. But we've been looking at what our current agency training is for anybody that works in other crisis services and analyzing what people already get as part of their agency training and what they may get on their units and what our expectations are in the training that we have in our crisis line. So we've been trying to create sort of an internal training, cross-training module so that we can maybe train folks on mobile crisis team or at our crisis walk-in center who might be interested in picking up some moonlighting shifts to help support the work of 988. Again, that's a pretty new process and we're still working the kinks out on that, but we're really excited about it and we expect that to go live pretty shortly. Woo, see how busy we are? So much going on, but all good things. And next slide, please. I think that was my last slide. And I did see my good friend Mona, who is one of my colleagues here at the Harris Center, did add my email address to the chat. So please feel free to reach out if you have any specific questions.
Awesome. Thank you to Ms. Pierre Carr, Ms. Battle, and Dr. Draper for your amazing presentations. We have some time to address questions from the audience. If you have not already, please type your question into the Q&A pod on your screen, and we will answer as many as time permits. And let's take a look at some of the questions here. So the first question in here has to do with geolocation. The area code of cell phones might not be where the person is located. Will it be using towers, and is that already figured out?
I can take that, Mike. Well, it's not figured out. Actually, the FCC has to rule on this. The FCC was asked to provide required to provide a report to Congress about geolocation. And they did provide that report about, I don't know, 8 months ago, something like that. And that report basically said, we think it's a good idea for the Lifeline. We understand the reasons for it. We're not sure about the overall feasibility and costs. And so basically kind of kicked it back to Congress. And Congress, I think, is waiting still on the FCC to have a hearing on it. And I think they were instructed to do so. And in fact, we're having such a hearing. It's actually a co-hosted gathering or consortium that's happening next week on the 24th that's hosted by SAMHSA and the FCC. I'll be there with a number of other folks in the telephony industry, in the communications industry, in the crisis services industry. 911 will be there. It'll be a very important event. So I don't have the information on me, but I think you can look up FCC geolocation meeting. Just look it up online and you'll be able to find it. You can register and watch it stream live. So I believe that's, again, a Tuesday, a week from yesterday.
Thank you, Dr. Draper. Next question, how are, and this is probably to Lucrece or even Jennifer, how are you collaborating with state 211s?
I'll take that. For us, we are actually in some conversations with 211 in terms of just kind of exploring backup coverage and things of that nature. So we're in beginning stages of conversations. The area that oversees that is we're in the same agency. So we are in beginning conversations to talk about 211. We do know that other states also leverage 211 in terms of answering calls. So we're exploring that as well.
And I can just speak from the local center perspective. We have a memorandum of understanding with our 211 and our county to specifically work collaboratively so that if we get calls on our crisis lines that are not crisis oriented, but are really resource rich, not behavioral health resource rich, but like, you know, they're looking for just general housing or financial support or food banks or things like that. Once we've determined that it's not a mental health or an emotional health immediate crisis, we can then do a live warm connection with our local 211 who can help walk them through getting connected to those resources. And that's been really important because taking the time to find the correct resources can take a while. And so being able to use the expertise of the different lines has been very powerful because it allows each of us to do what we do best, but it allows us also to get a bit available to get on the line for potentially more crisis calls. And then also for our local 211, their side of it is if they get a call that is a behavioral health crisis, that they can live connect that call directly with us and then we can handle it on our end. So it's very powerful and fantastic connection both ways.
And Mike, one other thing from a national perspective, about a quarter of the 200 centers in our network are 211 centers. And we know that from a recent survey that just about every one of our centers where there is a 211 center near them, they're coordinating at some level with. And with the state 988 planning grants that Lucrece was referring to that Texas received, just about every state in the country applied for that. It was a vibrant planning grant. They all established state coalitions for 988 planning, and many of them were making sure that the 211 and the crisis centers were sitting at the same table.
Awesome, thank you. This question comes from Benjamin Campbell. His question has to do with rural communities who rely on EMS providers and may not have mental health crisis training. How will EMS be supported with 988 going live?
At a national level, I mentioned earlier, there's going to be a 988 911 community of practice, and the National Emergency Medical Services Office at the Department of Transportation is going to be a part of those conversations. So we're going to be thinking a lot about how it is that we can help equip any emergency medical technician or any crisis responder, anywhere from a sheriff to a firefighter to an EMS responder. How do you work with people who are in mental health crises? And so what are some trainings that might work? But more importantly, what are some innovative models where we might be able to pair some of those folks up with mental health counselors and extend mobile crisis services in those areas? There's some interesting thoughts about doing that, such as co-locating crisis stabilization and mobile crisis teams in one place so they can cover a large rural area. Because you're not going to get a lot of people coming into crisis stabilization. You won't have a lot of people using mobile crisis, but when you do, you'll have economies of scale with one service providing both.
And Chris Dudley actually just put in the chat, CIT training for EMS personnel can also be very helpful with that too. Sarah Robinson asks, how connected will 988 be with 911 in terms of ease of involvement or possible involvement of law enforcement? There's also another question in here that can probably be answered with that from Jamie Michael. Do any of these calls come as a transfer from 911? So very similar question.
Jennifer, you got to talk about your model in Harris County.
You know, this is such a great question, and I love this because it shows everybody here is thinking big. And so, yeah, thinking big and thinking sustainably and thinking in a connected way. So there's so many cool models out there about how, and I see some people that have joined the meetings here who have, you know, St. Louis I saw is on the call. I think Arizona is on the call. Oklahoma is on the call. There's a lot of communities who are working on actively, maybe LA here too, working actively on these partnerships between 988 and 911. So our model in Harris County, again, because we're so big and the city of Houston is so big, we actually have people from our call center co-located inside of our public safety answering point inside the PSAP. So they're pulling mental health related calls directly out of the call slip queue and just handling them and diverting them so police or EMS never even go to the scene. And so if a call comes in that didn't get coded appropriately and still needs us, then they do just directly connect that call over to that behavioral health clinician who's on site. In other parts of the country, there is connectivity opportunities between, you know, 911 connecting, again, non-imminent risk, but behavioral health specific calls out of their PSAP into the local call center. So that does happen. And then there's been lots of conversation about, well, what happens if a call comes into 988? And again, very rarely, because I know that this is a fear everybody has, but there are rare occasions where there does need to be, you know, an imminent risk response. And if there is an imminent risk response, there has to be good communication between that 988 center, that local crisis center, and their law enforcement partners. And so that's, at this point in time, this is really a community by community conversation. In some states, shout out to Washington State, there really needs to be good communication and coordination at the local, county, and state level around what that's going to look like. Our friends here from EMS and from 911, you know, the idea is you've seen one 911 call center, you've seen one 911 call center, right? There's some that are very sparsely staffed, and then there's some big ones like ours, which has a lot of people. So you've really got to work on it a center at a time. And, you know, SAMHSA, our friends at SAMHSA have really put together, is it SAMHSA or NASHVID, John, the playbooks?
Both of them worked on it together.
Yeah. Well, I don't know, can you talk about the link to see those playbooks? Because there's one specifically about PSAP.
Yeah, I believe there's 3 playbooks. There's one for the states, there's one for the crisis centers, and there's one for, you know, PSAP interoperability with crisis centers. All that can be found on the 988 website for SAMHSA. If you just put SAMHSA 988 in your search bar, you're going to find it.
And we can probably, one of our team members here can probably put the links to those playbooks in the chat for everybody also. So
That'd be great, Mike.
We'll see if maybe Ashley or Erica could do that for us. That'd be great. So, and speaking of the playbooks, you know, the model that Jennifer speaks about is in that playbook, and the model that our next question comes from, Broome County, Kim Saunders, that model is also in the PSAP playbook. So Kim's question is that you mentioned there's a lot of subject matter expertise in the local crisis centers providing amazing service. What happens if that's not the case? What if there's no evident standard of care, and the real question of the call takers being capable in that role? So the question has to do with best practice assessment guidelines, so states such as New York can identify and hold providers to a common standard. And maybe in Texas, did you guys have a different expectation in standards? And how did you transition to a common understanding of scope of work and competency?
That's a great question, and we're still working on it. I think our standards for, as Jennifer mentioned, prior to the Lifeline, our local authorities are held to standards for operating our crisis hotlines and just our general crisis services. And so we're examining that now and thinking, okay, perhaps, looking at vibrant standards, perhaps we need to rethink some things and be more creative, especially with workforce challenges and in terms of credential staff, what we require. And so that's just a little snippet. And so we are in the throes of exploring that right now.
Mike, I wanted to just note that there are national standards for risk assessment, and what we're calling safety assessment, and also for helping callers at imminent risk of suicide. And they've been established after years of evaluations of crisis hotlines and establishing consensus among subject matter experts at the national level. And since implementing them, we've then done studies to determine whether or not those help or are effective. In this iterative process of evaluating the Lifeline, taking it to our standards training and practices committee and our steering committee and our lived experience committee, and then saying, okay, these are the standards, putting them out in the community, then implementing them, and then studying them whether or not they're effective, we have found that they have been effective. And so they are not only the standards for this country, but have been standards really throughout the world. This is the only what they would call national iterative process of crisis services that's been done in any country. And it's really been due primarily to the incredible work, not only of SAMHSA and our evaluation team, but of the crisis centers across the country. We've had over 70 centers that have participated in these evaluations because they want to do what is best for the person that they're working with and for. And the best way to do that is to learn from researchers. And we've also found that the best way to implement research from research to practice is to have the practitioners have contact with our researchers and learn from them, and vice versa. And that's exactly what's happened now for 17 years.
Maybe just a follow-up to that, Jennifer, maybe can you speak to some of the buy-in that you had to get from your law enforcement, or pretty much across all of the projects that you're involved in? A lot of the questions come up as far as how did you do that? How did you get buy-in?
Well, I always like to say, if I believe in it, just try to tell me no. But if it's the right thing to do, there's our friends in law enforcement and at the 911 centers, they're doing amazing work, but they're having to move closer to us than we're having to move toward them, right? Like, we know, just like John said, that we've been doing this work and that we're really comfortable talking with people through risk, people with weapons, and, people that other folks would, immediately say, like, oh my goodness, I can't believe, that you're talking with folks at this high acuity. And so for our law enforcement partners and our 911 partners, our EMS partners, really kind of like being patient and being willing to answer all the questions, and, playing them some calls, sometimes is what we've done too, and letting them come in and tour our shop and talk with our folks. These are long-term partnerships and relationships. These are not, hey, we had one meeting and everybody signed up and said, let's go for it. I see down here too, Melanie asked about co-responder teams. Working with mobile crisis and working with those co-responder with law enforcement and behavioral health folks. We have those things in place in our community as well. And each time you add something like this to your community, it enhances your capacity to continue looking at more creative and innovative things down the line. And so I think that this is a really key piece around, how, the trust. I mean, trust is key, right? Like, if you've never met me before and I just walk into your office and I'm like, hey, let's do this thing, that's a very difficult sell. People are not necessarily going to just jump right on board and go like, yes, I believe. We've had a chance to really think about these things for a long time, often before we walk in and talk with somebody. So I say, please just be patient. Please be patient. And if you need help, call me or email me or John or, any of us that are doing this work. And we're happy to talk you talk you through some of our strategies as well.
Thank you. There's just so many good questions in there, and we're running short on time. So I'm just going to field one more question from the Q&A pod, and then if our panelists have a few minutes to maybe pick up on some of those questions and answer them as typing them in, that would be great. The last question that we'll touch on is what level of cooperation do you have with veteran organizations such as Wounded Warriors? And that comes from William Williams.
I can say a little bit about that. We were mostly partnered with the Veterans Crisis Line, and the Veterans Crisis Line is engaged, I know, with Wounded Warriors. When you press 1 and you call 988 or 800-273-TALK, you have the option to speak with folks at the VCL, the Veterans Crisis Line. I know a number of our local centers are engaged with veterans community and veteran service providers and advocates. So Jennifer, I'm not sure if you or Lucrece, perhaps locally, there may be something else that you all are doing.
In Texas, we're in Houston specifically, and several of our states, we're partnered through SAMHSA as well with the marriage challenge for veteran and service family members suicide prevention. Sorry if I'm saying that wrong, it's a lot of words. And then we also have the governor's challenge, which is there are several states across the country who are working collaboratively. So all the same folks in Lucrece's shop and my shop across the state who are doing that work. We're working in partnership with multiple veteran service organizations, both the nonprofit sector, the city sector, the county sector, and at the state level.
Thank you to all of our panelists for answering those questions. So we're coming up on the end of our time for this panel. There are 2 resources that you may download now from the chat box. We have let you know that there is an attendance certificate for this panel. And if you're interested in downloading that for personal use, you can download that now from the chat box. You will see that our last poll for this session is popping up as well. If you would like to provide any input or additional technical assistance or other areas where you would like related information, then please indicate that. And this information will be shared with SAMHSA. And you can see the poll is popping up there now, and we'll answer that, and we'll get to the results of that as we report those to SAMHSA. If you haven't signed up for the Gaines listserv, then I encourage you to sign up, and the link will be here on the next slide. There it is. And just enter that link into your favorite web browser, and it will take you to a place to enter your information. And you can make sure you stay up to date with all of the Gaines Center's activities. Thank you again for your participation in today's event. If you have any other questions or comments, the Gaines Center direct contact is here on this website. And you can go to samhsa.gov/Gaines-Center, or here is a phone number to directly reach us. With that, I can't thank you enough for being here with us today. And thank you so much to all of our panelists. What an incredible group of subject matter experts that we had here with us today. And I'm looking forward to our next session that will begin at 2:15 Eastern time with another group of very talented subject matter experts. So thank you so much, everybody.